The People's Business is made possible by our partners, Solar Dynamics, the most efficient energy systems.
A very good evening to you and welcome to this edition of the People's Business Live. I'm your presenter, Ryan Broome, and tonight we're looking at the topic, the QEH, responding to changes in healthcare. And to help me do that, we have an esteemed panel with us. We have Dr. Christine Greenidge. She's the Chief Operating Officer and Acting CEO at the QEH. Also, Dr. Anne-Marie Cruickshank, the Consultant and Head of Department of the Accident Emergency Department at the QEH, Communications Specialist, and my former colleague, Shane Seeley. And also have the pharmacist, Ms. Trudy Griffith. We're back right after this break with an opening for the discussion. Welcome back to the People's Business Live. Again, we're our discussion tonight, the QEH, and responding to changes in healthcare. We get the discussion going with the Acting CEO and Chief Operating Officer, Dr. Christine Best. Good evening.
Good evening.
I want to start with a look at the renewed focus on patient-centered care. Could you tell us a little bit more about that?
Absolutely. Patient-centered care is based on the premise that we are all connected to that patient. Regardless of where that patient is utilizing our healthcare services, every individual who works at QEH must be connected to that patient. So patient-centered means that everything we do is around that patient. Visualize that patient being at the center of a circle that consists of many departments, many services, and of course, most importantly, we also like to connect that patient with his or her significant others and families as well. Oh. It's not a new concept. It has been around for many, many years, and it was the biggest flip, I think, in healthcare over the last 15 to 20 years, where all healthcare services are centered around the needs of that patient, whether that patient is at the beginning of life, as in birth, or near the end of his or her life. Patient-centered care.
Okay. Next, for opening remarks, we go to Dr. Cruickshank. You have the Action Center, the Accident Emergency Department. Always a topic of discussion, one way or the other. Yes. Tell me a little bit about the increase in the number of emergencies that you're seeing on a daily basis.
Yeah, we are seeing quite a lot of emergencies at the moment. Cardiac arrest, respiratory arrest, trauma, stab wounds, gunshot wounds. And also emergencies related to the chronic diseases that patients are not taking care of themselves properly and therefore presenting to the Accident Emergency Department quite ill. These emergencies take up a lot of our resources. They take up a lot of our medical and nursing staff, personnel, because we have to attend to them immediately or within a short period of time. And as a result of that, it does delay the time that we can get to other patients. So it's one of the challenges that we're encountering at the moment.
Okay, I'm going to save you for last, Mr. Seeley.
Yeah, ladies first. Ladies first.
Let the ladies go first. Next, we go to the pharmacist, Trudy Griffith. In your department, medication delivery services established to combat long lines at the QEH. Could you tell me more about that?
So when COVID affected Barbados back in March of 2020, we recognized that we needed as a pharmacy to respond to the needs of our patients. So we developed a medication delivery service where persons are afforded the opportunity to have their medications delivered straight to their home or even their place of work for just a small fee. It's an amazing service.
Of course. So, just reminding our viewers that you can be part of this discussion as well. You can call 228-5562 and 228-5563. I'm going to go back to the COO, the acting CEO right now, and just tell us a little bit about the QEH was recently in the press, recent press coverage of the laundry department.
Yes.
Give us an update on what's happening there.
This is just about a week or so ago when there was a headliner front page in regards to our laundry services. One of our washers had failed. But the important thing that I want the public to know and to understand that with machinery failure, every institution should have a contingent plan. That means if there's total failure, what do you do next? And we went right into our mode, which is to partner with our psychiatric hospital. We have extended our services from QH on many, many occasions when their washers failed over at the psychiatric hospital. And I must say that in full partnership, they were so pleased and happy to actually assist us. The washer was only down for about a day and a half, and we never missed a beat in terms of supplying clean, fresh linen to our patients. There was no interruption of any services at any time through that washer that was down. The good news is that in our capital budget, we have monies allocated for the buy-in of new machinery, a washer, and we are currently about to buy a 450-pound washer to assist us in the laundry services.
Okay, and I use that as a segue to you, Shane. Obviously, these issues come up from time to time. The QEH will come up in the news for one reason or another. Social media, as it is right now, everybody has a cell phone, so you know they're going to share and put whatever it is on social media. In terms of public outreach, you know, what's the plan?
Well, in terms of the plan for situations like that which would arise in the media, obviously the report in that instance would have suggested that the information came from workers within the department. The workers are, while they're free to share their opinions, of course there's a process, and that is something that we spoke to them about. And I mean, they were happy with the news, especially as Dr. Greenidge broke it, that they're going to get more equipment. The workers were frustrated because they want to work. So not having that facility at the QH at that point in time, they decided to take that course of action. But going forward, my problem really with this story, because there were several inaccuracies in the initial story. CBC would have reported it correctly, but looking at other sources where you say that a washing machine was out for over 10 years or 12 years when it was really only out from the year 2020, that's a stark difference, and it paints a whole picture on the story, because you go back to that year and you understand the supply issues. And these washers, you don't just buy them off of a shelf, or you don't just go into courts and say, hey, we want a 450-pound washer. These are things that have to be built from scratch, and of course have to be retrofitted specifically for what we do at the QEH in the laundry department. So there were some inaccuracies in that story, but moving forward, of course, we will be sharing with the media. I always have an open policy as far as sharing information with whether it be CBC or other media outlets, but also we will be making a big push as well to doing a lot more content ourselves, so that the media can feel free to use our content to get the information out to the public, because we are in that age where everybody gets the information on their phone. It's easy access. So social media, the QH, you will see a pickup on our social media pages. You'll see a pickup on our QH Connect website as well. So, I mean, all we can say for now is just to look out for more, because we will be also showcasing some of the amazing stories and some of the amazing work that our staff continues to do at the Queen Elizabeth Hospital. And particularly, so I mean, we just had a clinic, World Project Clinic, a World, I'm not getting the acronym that right, but it's a WPP project. World Pediatric Project, correct. Where scores of children were assessed by doctors They came in. It's a partnership with the Sand Lane Charitable Trust as well. But the doctors came in, assessed the children, and those children will be forwarded for further medical care. So these are just that's just a snapshot of some of the amazing stories that we will be sharing going forward, especially on our socials and on our website as well.
Okay, going to go back to Dr. Cruickshank now. The elderly care and young for care patients abandoned in the accident emergency department and the AED. Long periods of time taken to transfer these patients to the geriatric and other district hospitals. And I just want to add on to this here. It's often said, one of the things that's often said when the accident emergency department sees a large influx of people is that some people are coming or appearing at the accident emergency department and in cases where the circumstance of what's happened to them is not really come up to the height of an emergency. And then there's suggestion to use Winston Scott and whatever that is usually the one that's open at that time. In answering this, I want you to also address that issue in terms of how difficult it is to encourage people to utilize the other facilities, even though it's an emergency. Okay,
so as you rightly said, that we do have an influx of patients coming to accident and emergency. They're triaged, and some of them don't qualify for an emergency per se. They have a lower acuity scale. And we would encourage them to go to the 24-hour healthcare clinic or the polyclinic. But many of them don't want to go. And we can't force any patient to go to another facility. So inevitably they stay, and obviously they have long waiting times. So it becomes a challenge for us. We also have the private emergency clinics sending patients to us, just for continued care because they have reached a certain point where they can't go any further. So obviously that would mean that we have increased numbers coming into accident and emergency, and obviously we have a set complement of staff. So you can understand that the waiting times will be increased with that increased load of patients, those who walk in, those who come by ambulance, and those who come by private emergency care facilities and their ambulances also. So that's a challenge we have, encouraging patients to tell them that you don't really need accident and emergency per se. You can be seen at your clinic, you can be seen at your general doctor, you can be seen at the 24-hour urgent care. But if they feel that they don't want to go, we can't force them to go. And that's a challenge we have.
Okay. I believe we have our first caller. Caller, please go ahead with your, good night, go ahead with your comment or question.
Hi, good evening.
Young for care. They come to the accident emergency department obviously for medical attention. We treat them, and on discharge, when we're ready to send them home and we call family members for them, we're told that they cannot receive back the patients. So they're left with us. As a result of that, our social worker has to do a case study on them to investigate their social circumstances, if their house is fit for them to return, family members are able to receive, and family friends. And most times we were told that they're not able to receive. They've done all they could for that patient and they're not able to take them back. As a result of that, we have to house them. We have to take care of them in terms of their physical needs, their medical needs, psychological, and, bathe, feed them. And that puts a burden on an acute emergency care where we're not set up for that. And up to recently, we had 9 elderly and young for care taking up a 12-bed unit, which is our short stay unit. So that means we have reduced number of acute patients who need to be on that unit taken up by elderly for care and young for care. So it's a major challenge.
Yes, it is. And Dr. Cruickshank describes the scenario in the AED, but certainly on the wards, it becomes even more of a problem because our beds are designated for acute care. So many times we have numbers of EFCs, elderly for care, in the 30s, sometimes approaching 40s. And that type of bed capacity should be used for acute care. And they're literally there. So here's a scenario when it's time for discharging these patients. Once they're stabilized medically, and we call families, oftentimes we have numbers that are incorrect. We try to go to the homes, doors are not open. And the sad part about it is that these are pretty much well medically care patients, and they want to go back home. It's grandma, it's grandfather, it's mother, it's dad. And these are the people who built the fabric of our society. And in their twilight years, they want to be home. They often, is so emotional for them as well as our staff, because we see these people crying, I have a house, why won't they take me back home? I want to go back home. Not every one of them have dementia. Many of them are of sound minds, and they have expressed that. So something has gone very wrong in our society. Certainly as a child, when I grew up in Barbados, the village took care of elderly. It was something that we just did. Everybody pitched in and took care. But we're seeing this phenomenon now that literally, and interestingly, if we look at the demographics around, it's very seasonal. So we start to peak during crop over time, and it steadily increases towards Christmas. Wow. And we have recently, this was very heartbreaking, a daughter of a mom who we call to pick up your mother. Your mom is fine, can go home. She has expressed that. Her own house, where this daughter lives with her significant other, and refused to come for mom. Wow. So these are the real stories that our staff face every day in the challenge of trying to tell families to come back for your mom, for your dad, for grandma. It's not the place that you want someone who has really now in their senior years should be comfortable in an environment that they're familiar with. And especially if they express that, verbalize that. We can't really put deaf ears to a plea such as that.
Yes.
Okay. I believe we have another caller on the line. Good night, caller. Please go ahead with your comment or question, and please lower your television so you don't confuse yourself with the feedback. Go ahead, caller. Good evening. Good night, caller. Please go ahead with your comment or question.
Yes, good night. Good night to the panel. This is for the accident and emergency. Hello?
Yes, I'm hearing you. Go ahead.
Yes.
Okay.
No.
2 friends of mine went down there last week. They didn't feel well. Them as old people, and they had to wait 2 days before to see a doctor. And that is poor service. Poor service. And then an old lady then in there, and she then laying down on the floor. She cursed the guard, and then the guard went and bring something for her. 2 days down there waiting to see a doctor is a poor service for a hospital.
I'm gonna relay the call for you. The caller is basically saying that there was a patient in A&E for 2 days, and she's very concerned that wasn't good enough. That's what the caller was just saying.
Was the patient waiting to be seen, or was seen and waiting for treatment, review, etc., by the specialist, because
Well,
that's something
she didn't mention that part in particular, so I'm not sure.
What?
But there's a distinction there to be made.
Yes, yes, we do acknowledge the waiting times have been protracted recently, but when patients are seen, they then have to be seen by the doctor. They have to get all their investigations done. They have to wait for those results. We have to refer them to specialties to be seen, and then they may have to be admitted, which might take a little while in terms of the beds on the wards. So it's very easy, yes, to be in accident and emergency for 2 days as you're processed along your treatment path.
But are there any solutions? I mean, we talked about the 24-hour service, the alternative.
Yes.
You said some people are not willing. You can't force people to leave.
Yes.
But is there perhaps a way to either provide a shuttle service from there when you recommend somebody after they've been triaged? Okay, it's best perhaps you go there so you don't have to wait here any longer. Or alternatively, what I was thinking is if the pressure isn't as much at the 24-hour facility, if resources from there could be sent to A&D, are any of those options that have been considered?
Yes. We do have a taxi service. The hospital taxi is willing to transport patients across to the 24-hour unit, and that is available. The 24-hour unit is not set up exclusively to manage all emergencies, but if they do need supplies and or any equipment, we are willing to transfer it across to help them. And similarly, they have helped us when we are overloaded with our patients. So we do work in conjunction with the 24-hour unit clinic to assist us, when they can.
Okay, just going to bring you back in here, Ms. Griffith. I know we've been over this site for a little while, but pharmacy is always an important part because medication is an important part, especially for the elderly patients that will be seen at the hospital. Tell us why it's a good option.
So Ryan, I'm sure that many of our viewers do not know that the pharmacy sees between 500 and 600 patients every day. Now you can imagine that that's quite a burden for the pharmacists, and if there are any staff shortages, that becomes even more of an issue. So instead of persons leaving their homes, perhaps catching 2 buses to come to the hospital and wait for an extended period of time to get their medication, you can simply call our dedicated delivery hotline, or if you're tech savvy, you can go on the hospital's website and you can order your medication and have it delivered straight to you.
Okay. And you want to say something, Sean?
Yeah, I was going to say, in addition to the part about tech savvy, and that's where we come in, as in we help our mothers or grandmothers,
Yes.
so that they wouldn't have to bear in any long line. I mean, when you're seeing 500-600 patients a day coming for medication, that's an area of congestion that we're trying to clear using the delivery service. So it's up for us too to pitch in and help our elderly relatives
Yes.
with the service, help them to understand that they can stay at home. Just $10, Ryan. Just $10 can save you hours of waiting
Definitely.
time in the hospital. And there are some other areas of congestion too that we're trying to clear up in the hospital, especially as far as appointments are concerned. Right, Dr. Greenidge?
Yes, absolutely. And I just want to piggyback up in terms of the whole idea of congestion. And so relatively healthy people, we don't want them really to come into the hospital and have to sit hours and hours in an outpatient pharmacy area waiting on prescriptions. And recently I was very curious. When I came to QEH a year and a half ago, I met with Trudy and she told me about the program. And I said, I'm just curious as to whether or not the public is aware of this wonderful service. Very convenient, very safe. And about 2 months ago, on my rounds, I stopped by the outpatient pharmacy. And there were about 70, 75 people in the vicinity waiting. And I asked a simple question. How many of you are aware of our home delivery service? And out of the 75 plus people, about 4 people raised their hand. Wow. 2 of whom actually utilized the service. So there was really a public lack of knowledge about something for nominal delivery fee of $10 is available. So, why have mom and dad and grandma and grandpa venture to the hospital to sit to wait for prescriptions? So we really want to promote that aspect of one of the services that we offer.
Okay, that's a good point to take a break. We'll be right after this break. Remember, we're taking your calls, 228-5562, 228-5563. We're back after this break. Welcome back to the People's Business Live, where the discussion tonight is the QEH responding to changes in healthcare. And we're going to go straight to a caller. Good evening. Caller, please go ahead with your comment or question.
Good evening. Just want to follow up on the comment that was made earlier about the $10 from the pharmacy. Isn't there a possibility that the QEH can look at expanding other services that can be cost-effective, that can buy into, that will increase the hospital's financial position? There are people who can afford to pay for some services at the hospital. We don't need to provide everything kind of. That's one comment. Two, I was a patient at the hospital, and I saw something that really was disturbing for me. I was on the A&E, and two gunshot victims came in, and the resources that was used, Ms. Cruickshank Dr. Cruickshank could probably speak to this, the resources that was used, at one point, the one bed had 10 persons around that particular shooting victim, and another had 18 persons. This is a significant cost to the hospital. Isn't there a way that this can be dealt with the specialized wards for shooting victims and certain types of accidents and stabbings? That's two. And the third comment relates to the I'm trying to remember what it was I was going to speak to. But those are two areas that I would like to have some response to. Thank you very much.
Okay, Carl, I'm going to have to relay your questions because the panel could not hear. His first question related to additional services that the hospital may be considering. He believes that there are some services that people can afford that the hospital can explore. In other words, he believes there are some people may be taking advantage of a free healthcare system, which essentially is, but some services that he believes that you can put a price tag on in terms of raising or increasing the revenue of the hospital. That's the first question. And his second question relates to gunshot victims, which Dr. Cruickshank has already referred to. He was expressing concern that he was in, I believe, A&E at the time. And as soon as a gunshot victim came when he was there, it was like everybody else who was there they ceased to exist while all of the resources went towards that gunshot victim. He wants to find out if, given the prevalence that we've been seeing with those things, if there isn't a separate ward or separate resources that can be specifically dedicated on standby for gunshot victims in particular. So those are the two questions. Whoever wants.
I'll start. Unfortunately, we only have a set number of doctors on each shift. And a gunshot wound, as we mentioned before, is a category 1, especially if they're in hemorrhagic shock. And all personnel will have to manage them because they're going to go straight to the resuscitation room. They're going to require quite a lot of services, and we have to stabilize them. And also we have to call the specialties, for example, the surgeons, to come down and assist us. So at that point in time, yes, unfortunately, the other patients are on pause while we try to stabilize those type of patients. And that's, as we said before, one of the challenges we're experiencing with the gunshot and the stabbing and this sort of trauma. They disrupt the services, and the other patients suffer as a result of it. So we don't have a standby crew of staff. But if it occurs when there's an overlap of staff, one set of staff can see the other patients, and the others would manage the resuscitation. So it depends on the time of day the patient is presenting.
So the public needs to understand that at the point of entry in the emergency room is something called triage. That's where an assessment is done in terms of the presenting symptoms that someone may be coming through our door with. And categories 1 or 2 are epitomizes what an emergency room is all about. That is usually patients who are assessed in a category 1 or 2. It's typically life or death. So besides the gunshot wounds, the stab wounds, the MIs, the heart attacks, the strokes, all of those are clustered into that category of patients, which mean immediately, because it's life and or death. So if someone is waiting who may be a category 3, and there are 5 categories, 3, 4, and 5, category 3 represents 60% of the patients that we see in the A&E. Categories 4 and 5 are much more minor. Ideally, those are the patients we want to see and treat and have them go home and or follow-up care in the polyclinics. So it's a rating within the emergency room. So the public may see a perception that I'm here and everything stops, but this is what emergency room is all about. This is why we're here to educate the public that based on your symptoms, that the polyclinics are there to assist you as well, so that we can decant and really, truly provide services at an urgent and or very emergent need of patients.
Okay, I believe we have another call on the line. Go ahead, good night, caller, please. Go ahead with your comment or question.
With the services that they can provide at the hospital to pay for that.
Turn down your television, please, so it doesn't confuse you. Caller, please go ahead with your comment or question and make sure your television is turned down.
Hello.
Hello, good night.
Yeah, good night. The problem that we face in the hospital is these people that live in the hospital care for the elderly. Now, the family don't want them home, but they're home receiving the people checks. What the hospital need to do, notify the national insurance when the people is living in the hospital, that will do something about the checks. If you don't want the family, if you don't want the people home at you, how can you want the checks? The hospital need to notify the national insurance and say that so the person living here for weeks or months and the family would not come for them. Therefore, we need to stop the pension checks from going home. Let the national insurance something to do with it, either send the hospital to help feed the people. If you want the people, if you don't want the people, you don't want the family, you don't want the checks. That is what they need to do at the hospital.
Okay, were you able to hear the question? Caller is saying this is based on what we said before about what happens to some elderly patients where some children are not taking them back home, that the hospital should contact the NIS to let them know that these people are being fleeced, really, that the family is cashing their checks, but they're still in the hospital. So her suggestion is that the hospital make contact with the NIS to, I guess, identify these people who are abusing their elderly parents and grandparents.
It's part of our social service that will follow up on the issue that the caller raised, which is very, very factual in when we investigate the circumstances of our elder for care that reside literally until birth confined placement, usually in our geriatric facilities. But one thing that I want to say in analyzing this, it is very important that if you are a son, a daughter, a grandchild of the elderly, that you start to plan for longer term care. It's just not good enough to drop off grandma here and then have them live here. You can contact social services to assist you in planning that long-term care, but it also speaks out for the need. There's an obvious need for more longer-term facilities in our country so that, one thing, Barbadians live very long lives, and the time has come for us to understand that, and therefore part of life's planning should be the care of the elderly. It breaks my heart. You can't fathom someone who does not have dementia and want to go home. It's familiar. We should not deny that. And we understand, yes, people are busy. It's a busy world. But you know what? Here's someone who reared you. I was raised by a grandmother for the first 6 years of my life. And I just failed to understand fully. I think I can understand the reasons why someone may, but in totality, we have a problem here, and we need to look for more long-term placement. The other thing is what we see occupying some of our beds, near end-of-life care, known as hospice care or palliative care. These are things that we need much larger in the society because, there's no reason why someone who's in terminal illness has to die in the hospital. There are other facilities that will help that transition to the next life and make sure that end of life is comfortable, is dignified, and there are places where this can happen. So I think that in large in our society, we need to look more long-term in that aspect of care and don't have the people in the acute care facility.
Okay, thank you. We believe you have another call on the line. Caller, good night. Please go ahead with your comment or question. Remember to turn your television down.
Hi, good night.
Hey, good night.
Okay. I have question is, what takes so long for the medical records? I've spent 4 hours waiting to get an appointment. The process isn't very difficult because you have your information. So why does it take such a long time between the time the numbers are going through? And then my comment in general, an earlier caller mentioned spending 2 days in the accident and emergency as an elderly person. I have spent that time there with my mother who has dementia. When we are intake, they take all this information with regard to the health of the patient and the things that are wrong with the patient. In my experience, these things are not taken into consideration then with our wait time. You have I've seen an elderly lady stripped naked because it was so hot and uncomfortable, but there's no one who came to attend to her. I was there with my mother. No one was there with her. But what I'm saying is, well, it's not the hospital's responsibility. There must be things in place. Policy is one thing, but people are variables. So there's so many different things that can happen. So there must be something in place to pay attention to these little details that seem to slip through the cracks. And that's my comment.
Okay, I'm gonna go with the responses when we come right back right after this break. Okay, so this person was. Welcome back to the People's Business Live, where the topic tonight is the QEH and the future of healthcare. And before we went to break, we got some questions from a caller. One of those questions related to the appointment system that the hospital has. The person says they wait for hours to get an appointment. But not right to get an appointment. They're saying that when they wait for that length of time, they're told that they get a call at some point in time when they get an appointment. And then the second concern they had was accident emergency for elderly people and people specifically who suffer with dementia. They believe that there should be some provision for those people who are waiting there for so long, some special provision made to accommodate them or to make them a little more comfortable within the A&E space.
Yes, I will take on the caller's concern around appointments. And we have to back up to the year 2020 that really changed appointment schedules because of COVID. And many times we were unable to see people in person, and therefore a lot of folks became victimized because of the inability to come in person to be seen. So fast forward to today. So that back up from 2020. A couple also in the fall last year when we suffered that cyber attack further impacted our system to be able to schedule appointments. So the third factor though around appointments is the volume of patients that we're seeing. In particular, I will talk about ophthalmology because I know for a fact that right now a new appointment for ophthalmology is right now in the year 2024.
Wow.
So a lot of people for the last 2 or 3 years did not have appointments. So the volume grew in terms of how many patients need to be seen, and that has really pretty much clustered our appointment schedule. So we are working on that. We encourage people to, many folks have a cell phone and they can go online and do their own self-appointment, but many people like to come into the hospital and sit and wait for to be seen by someone who can generate an appointment. For example, if you look at the area where the appointments are scheduled, many times people are waiting to have a follow-up appointment. There is a box there that we can fill out information and they will be called for the next appointment. But folks, many people prefer to sit and wait to have that human contact. But we are doing better based on the services that the individual may be coming in for appointments. They can vary sometimes as short as maybe 2 or 3 months. And in the case of ophthalmology, because of eye disease and the number of eye diseases that are out there can be extensive.
Okay, we have that appointment process, just doubling down on what the crew would have said. There is pretty easy. You can go to Google, type in QEH, and then you would see the website come up, QEH Connect. You go there, and it's right on the home page. You go and make your appointment, and then you'll get that follow-up from our personnel.
Okay, we have another call on the line. Caller, please go ahead with your comment or question. Good night. Caller, good night. Turn your television down just to be safe. Go ahead with your comment or question. Good night.
Good night. Hello. Good night.
Hi, good night.
Hi, good night.
Good night. Go ahead, caller.
Yeah, my concern is why you would schedule a young child for surgery. For 3 years, every time you have an appointment, there's no one to see her. But then you will call one morning and say if she can come for surgery at 8 o'clock without that child being assessed or anything during those 3 years. I don't think that is fair because you don't know if that child is in a physical situation to have that surgery that particular day. So I think that when you schedule people to come for their checkups and their appointments, the doctor who they're supposed to see should not be unavailable for all that length of time in a 3-year span, or a different doctor is not available that they can assess that child. That's my concern.
Okay. Concerns about appointment as it relates to surgery.
Children.
Surgery for children, yeah, in this case.
The caller basically believes that it's possible that that child may need the surgery urgently. So to go into a situation where you have an appointment, the doctor who is supposed to do it is not immediately available, or if it's an urgent situation, I think basically that's what they're trying to say. They mentioned a child, but I guess you could apply it to almost any category really, an elderly person as well. Is there provision for when you make an appointment, given the nature of what you're trying to seek, surgery in this case he's mentioning, that particular surgery is urgent, is there provision that you don't have to wait what may seem like an inordinate length of time? And I'm not talking about ophthalmology, I'm talking about,
surgery in general. Oftentimes, if that person has seen the physician, whether in clinic or sometimes they may see the physician privately, based on the symptomology that the physician is facing, he or she will deem the urgency of that surgery. And life-threatening need for surgeries, they're dealt with because they're just that, life-threatening. If the procedure is of such that we cannot immediately provide that care, then we do something called a medical scheme where we will literally, I don't want to say outsourcing, but it's a type of outsourcing that particular surgical procedure to a neighboring country. We've done that extensively, so we don't really delay on any type of surgery that quality of life is going to be affected and or the life or death is a factor there.
Okay, and we're going to go to another call now. Caller, please, good night. Please go ahead with your comment or question.
Good night. I have a negative, positive comment to make on the hospital as it relates to an experience I had there. I also have to make a recommendation, which I think is valid, as I think it would ease some of the load in terms of the number of non-emergency persons coming to A&E. I had the experience of calling for an ambulance. I asked the person in the ambulance if I have to go to the hospital. He told me yes. I was wondering if the incident is not an outright emergency, gunshot stabbing, why can the person be first taken to fast track or taken to the polyclinic for first observation and be dealt with there, and if it then requires the person to come over to the hospital, then that referral will be made.
Keep going.
That referral can be made. As it relates to my negative, positive relationship in terms of the hospital, I think although you have good intentions and what you want to do, sometimes the personnel in the hospital, the orderlies, the nurses, whoever, needs to convey to the persons in the hospital the information a little differently. I had the experience of a very negative experience. I don't want to be detailed about it. In terms of referring information to myself, and the person was very, very, very. I don't want what words to say, but it wasn't very pleasant. I think if that first has to relay information to a funny hospital and can relay information, record it so the person can understand the reason why you're doing what you're doing, then things will be more acceptable in that respect. I think I will close there. Listen for your comment.
Okay, Shane.
Well, basically the caller there is concerned about the treatment in terms of how our staff respond to them, and just clearing the message and clearing the ear is something that is a work in process. Our internal communications is something that the COO has placed at the top of her priority list, and that's why we recently had a town hall for a lot of our staff. About 400 staff came in, and they got a chance to air their views on ways that we can improve our operations at the hospital. And this was the brainchild of the Chief Operations Officer. She wanted them to be heard, and I think we are creating a template where we can action some of those concerns, and those relate directly to patient care as well, so we can improve our response to patients coming in to the hospital. Maybe you want to mention a bit more about the town hall and why it was so important for us?
Absolutely. We recently conducted a staff satisfaction engagement survey, and there were recurrent themes that actually came out of that survey. And as leadership, we cannot ignore. And number one was communication. So the idea of the town hall was just that. Unscripted, no agenda, staff come, you're going to be listened to, and because you're bringing concerns, then your leadership team will be charged with action plans to address them. The forum was wonderful. Staff, I got wonderful feedback, because I think that our employees, over 2,000 employees, they come to work to do their best. And oftentimes, if they don't have what they need to do the best that they can, that becomes a charge of leadership. So we want to hear them. Many of our solutions lie within our staff. So I have to set the tone where staff trust leadership, trust that they're going to be listened to, and trust that we are not just going to be talkers, but have action behind a plan to help them do the best that they can. One thing I want to talk about in terms of our staff, and yes, we monitor complaints. We hear some of the issues in the A&E. We hear some of the issues waiting in outpatient. And one thing I want to say quite clear, there's a zero tolerance for any staff who is rude, who is obnoxious, and who think that they can get away with speaking to people who are here to act or who are here to receive our healthcare services.
Brian, I can tell you
it's unacceptable.
Yeah, for sure. And I can also tell you that the QEH is one of those places which is an easy target for complaints and for criticism. But the QEH is also the leading healthcare institution in the region, not only in Barbados. And there are stats to prove that as well. There was recently a survey and some compliance that we received as well. I know the COO is very happy with the accreditation that we have received. Some platinum accreditation.
Well, not yet.
Not yet.
The results should be out this week.
Let's take a minute. We're gonna have to take. We try to take one more call before we wrap up. Time is running out. Go ahead, quickly call with your comment or question. Good night.
Hello. Good night.
Good night. Go ahead, sir.
Good night, Dr. Cruickshank. I want to ask a question. Is the QEH the right place for dementia? Or I believe people generally go to the private physicians and they examine them. I want to know where in the QEH is the right place for dementia. That should be done by therapy or something, other thing put together. I don't think that going to the QEH for dementia makes no difference than any point, because of dementia is something that the RNA physician and doctor should be able to guide you on down the road, put you on certain things on the road. I don't think the QEH is the place for dementia. It's a waste of time. I thank you.
To Cruickshank, you already called?
Well, the caller was asking if the QEH is the right place for patients with dementia. He thinks that there should be another option.
It really depends, I would say, because patients with dementia also get sick, and they can present with what we call is delirium. And sometimes you're not sure if it's dementia or the delirium. In delirium, there's some sort of underlying infection that is causing the person to be confused, what we call altered mental status. They may have a fever, they may have a respiratory rate quite high, blood pressure quite high. So persons with dementia can also get sick and can present with any type of emergency. So I would never say do not bring your patients with dementia to accident emergency. Bring them. Let us see what is going on. Let us go through them. We obviously have to do some investigations on them, bloods, CAT scan, etc. And then we can decide if it's a delirium or dementia, because dementia is a diagnosis that really you just don't put on a patient. You really have to go through them thoroughly before you can make a diagnosis of dementia.
Okay, and as I said before, we are rapidly coming to the end of the program. So closing comments now. I'm going to start with you, Ms. Griffith, for the pharmacy. Just you can even touch on reliability as you close.
Right, so therefore we have actually put in place a process where patients get their medications within 3 to 5 business days, and that also applies to prescriptions as well. So for persons who've been to the clinic and they have been issued a prescription, they can have that medication delivered as well. So what we want persons to be aware of, because we ask you for that information, we need your contact details, and we ask you for that information so that we can ensure the most timely and expedient service. So you can call our hotline. The number is 536-4804, or as Shane had mentioned before, you can visit the hospital's website, navigate to the pharmacy page, and click on the tab that says medication delivery. Follow the directions and you can order your medications and have them delivered to you. Let me also add that the hotline or even the website, we use that as a platform if you have any questions about your medication, because it's quite important that we make sure that you know everything you need to know and that we can answer any questions that you have about your medication.
Okay. Really quickly, Shane?
Yeah, we just want people to understand that QEH Connect, we're connecting with you. QEH Connect is your friend. Use it. There are a wealth of tools there that will help you to improve how you receive health care from us at the QEH. So QEH Connect, and of course, you can check our socials as well. We'll be putting a lot more content and information there to assist with this process.
Okay. Dr. Cruickshank.
I just want to stress that the Accident Emergency Department is an acute care setting. As we said, we have scores from 1 to 5. Obviously, 1 and 2 have to be seen immediately. As Dr. Greenidge said, Category 3 make up 60% of our patients. 4 and 5, less numbers. So when you're triaged and you're advised that you're a 4 or a 5, we're asking you, please, go to the urgent care centers, go to your polyclinics, go to your private doctors, and therefore decrease the numbers that come to A&E so that we can give the care to those patients who need it the most.
Okay.
I want to take the 3 letters QEH and share with the public the vision for the hospital. and that is quality, exceptional healthcare services. And we are here for the public of Barbados. We are here to put our patients first, and everything we do, regardless of title in the hospital, is geared around putting that patient at the center of our services. So you entrust your care to us, and we want to ensure that we provide not only meeting your needs, but meeting your needs above and beyond. Thank you for having us here this evening.
And thank you to Dr. Greenidge. Ultimately, we do need a fully functional and high service hospital. As Shane said, it is our lone major medical facility, and going forward, we need everyone to come on board, really. I just want to thank my guest again, Dr. Christine Greenidge. She's the acting CEO and Chief Operating Officer of the QEH. Dr. Anne Marie Cruickshank, the consultant head and head of accident emergency department, and the pharmacist, Dr. Trudy Griffith, and communications specialist, Mr. Shane Seeley. And thank you for your calls. Apologies to callers that we were not able to get in. We know the phone lines were busy. I'm Brian Broome. Thank you for being with us tonight. Have a good night.